bacterial, TB, mycotic, all of these things. But some of these you have to remember. Collagen vascular disease, you have to remember. In your clinical practice, always remember this: drug abuse, vasculitis. And we have seen so many cases now in our clinical practice of drug abuse, and particularly what we call recreational drugs, amphetamines, etc. People using them on weekends. And we have seen so many patients, at times they will not tell you the history, they will hide it, and actually it was vasculitis. And otherwise you are going, is it MS, is it not MS, and things like that. So this should be up there. I don't think so for the exam, it's an important point, but for your clinical practice, always remember this. This is a case of migraine. Just to make a point, in migraine, high signal intensity foci are very, these are punctate. These are quite often seen. And the only thing to differentiate with MS is, look at the distribution. These are subcortical usually. And they are not classical Dawson finger and all those things which we learn for MS. And this is small vessel ischemia. Now, small vessel ischemia after the age of 60 has got patterns which can depend. So if the patient has got diabetes, etc., or hypertension, you will have more confluent high signal. So the pattern is different. And age will be parameter there. And MS is always young age. There is an entity where old literature, which I'm going back to 1990s, and American literature particularly used to use this word senile onset MS. And you won't believe it that the word senile was used with MS, which occurs at the age of 50 or 50 plus. Now, nobody will use this word in this age. In UK, we know that till the age of 60, we use the word young. Between the age of 60 and 70, we use the word middle age. After the age of 70, it becomes old age. What I'm telling you is very relevant for those of you who are logged in from overseas, because it's a cultural thing that this is how you tackle it in the exam also, that this is a young patient. So remember, till the age of 60, everybody is young. Yes, please.
Okay, so presented with multiple axial slices of a non-contrast enhanced CT head of a 50-year-old alcoholic with confusion. There is periaqueductal hypodensity.
So is this periaqueduct? What part of anatomy is this?
No, it's not periaqueductal. I apologise. That's in mid-pons.
Pons, yes.
Yeah, it's in the pons. Apologies. And I can't, in the remainder of the slices, there's no global mass effect. I can't see any other hypodensity. I'm concerned that this could be central pontine myelinosis.
Excellent. So central pontine myelinolysis is an exam case. And please remember the concept that what was the classical teaching? Look at the word central pontine myelinolysis. We have this concept that if a patient has got low sodium hyponatremia and you treat this sodium, quite robustly or fast, there are some clinical rules. You should not treat it, more than this much millimole per 24 hours, which is irrelevant as a radiologist to know. But having said that, if you do it, then there can be demyelination, and this demyelination occurs in pons, and then you call it central pontine demyelination. By the way, it can be very severe or significant condition. There is mortality and morbidity. But later on, we came to know that it is not just sodium. It is not just correction of sodium. It can happen with other things like, blood, urea, nitrogen, hyperglycemia, things like that. If you treat it robustly or too vigorously, should I say. And the demyelination, it is not a must that it will occur in pons. Remember, it can basically occur anywhere. Where can it occur? It can occur in the cerebellum, it can occur in the white matter, in the thalamus, in the basal ganglia, anywhere, So some gray matter can also be involved in directly, deep gray matter. So now we use the word osmotic myelinolysis. And there is a pattern. There are three types of patterns now which are described in the books. In one pattern, only pons is involved. In second pattern, mix of pons and extrapontine demyelination. And interestingly, there is a third pattern in which pons actually is not involved. So remember that also. So you can have osmotic myelinolysis without involvement of pons. This is your case. And here is MR, which showed us the same changes, no enhancement. Yes, please, over to you.
Okay, so I've got multiple series of flare axial and DWI axial of a 47-year-old who is unconscious for 4 weeks. There is diffuse hyperintensity in the central white matter of the centrum semiovale, and symmetrical hyperintensity in the those the middle cerebral peduncles.
Excellent. So middle cerebral peduncles.
And they restrict on DWI on that focused area, and
so bright on DWI and still bright on ADC. But
okay, so that's T2 shines through.
My question is more anatomy. So you have picked up this, and there is internal capsule. You see this internal capsule?
Yeah.
And this thing was actually this.
Oh.
So this patient presented with diabetic ketoacidosis, treated for glucose and electrolyte imbalance, and this is what happens. And just to make a point here, you can see that the pons itself, maybe the peduncle is involved, but the central pons is not involved. And to make a point that osmotic myelinolysis can happen without the involvement of classical middle pons. Can you see a CT scan on your screen?
Yeah.
So over to you. This patient, the history is 1 year and not well, fever and things like that.
So I've got axial slices through a 1-year-old's brain who's generally unwell with fever. They are contrast enhanced. There is generalized contrast enhancement, most notable in the frontal lobes bilaterally.
Describe this enhancement to me, where it is. I want to hear anatomy.
The enhancement follows the gyral surface, so I feel that this is more of a leptomeningeal enhancement rather than a pachymeningeal enhancement.
Excellent. So what is your conclusion?
So diffuse leptomeningeal enhancement. So, and in a patient that's got a fever and is unwell, infection as a cause of that.
Right. Okay, you can mute yourself. Thank you. And candidate 3 should raise the hand. Let me do a bit of teaching points on this case. Now, I am going to show you many cases of infections. We are going to go very fast. This is pattern recognition. Some of them are repetitions, so we'll go fast. But there are a few learning points here. This is a case of meningitis. And if you can see that there is enhancement of the surface of the brain, this is on the surface of the brain is what we call pia mater. So leptomeninges, as was, something which dips down the sulci, it has to be leptomeninges. But here is a space which is subarachnoid space. And if you look carefully, because we have given contrast, there is enhancement of the vessels, normal vessels. And when we give contrast, this is how you can differentiate that this is subarachnoid space and not subdural effusion, which can occur. On an MR, you don't have to give contrast, but on a CT, you can do this. So it's a good, tool to differentiate between subarachnoid space versus subdural space. If the vessel is going through it, means it is subarachnoid space. And you can see it on a CT scan if you give contrast. On an MR, or you can see it as a filling defect even without contrast, particularly with multi-planar sequences. Okay. Spot diagnosis.
Hello.
Yes, candidate 3. This is a, you can hear me? Candidate 3?
Yes, I do.
Yeah, so this is a very easy case, but I just wanted to include it for completion. What is your diagnosis?
Herpes encephalitis.
Excellent. So if you see here in herpes encephalitis, what happens is that high signal, particularly the medial temporal lobe, or the what we call, this insula and subcortical subfrontal region, particularly this case is classical. All of you can diagnose it, so we'll crack on. Nothing difficult in this case. Again, very easy case, but what is this?
It says extraaxial, mostly subdural abscess from the sinus.
Excellent. So, in head and neck, which we are going to start next week. Next week, I'm going to start with temporal bone, and in head and neck, I do teach a lot of anatomy because I know that head and neck is all about anatomy. So next week, this Thursday, we will start head and neck and mostly temporal bone. So in head and neck, infections are very important for your exam. Complications of head and neck, infections, particularly intracerebral and things like that. So this is an epidural or extradural empyema with the complication of sinusitis, and you can see it here also. Okay, this is a good case, so if you can describe it. Let me, for the audience, tell you the sequences. Here, there, P1, P1 with contrast, P1 without contrast, P1 with contrast, and this is a cis sagittal. Cis is constructive interference in steady state. We have covered it when we covered the MR basis. So over to you.
Okay, so
I'm going to give you marks for your description.
Okay, so the first thing that caught my eye is the basal meningeal enhancement surrounding the brainstem and in the interpeduncular cistern, as well as the ambient cistern. This is also appreciated on the sagittal post-contrast sequence. I can also see hydrocephalic, supratentorial hydrocephalic changes. I can see also high flare signal intensity bilateral symmetrical surrounding the frontal and occipital holes.
Excellent. Conclusion?
Conclusion is basal meningitis, maybe tuberculous meningitis, maybe pyogenic meningitis complicated by hydrocephalus.
So, pyogenic, is it up there in your differential? So, meningitis is fine, but etiology, my question is regarding etiology.
Yeah, mostly tuberculous or sarcoidosis, but given the fever, I'd be more inclined to bacterial meningitis or tuberculosis.
Yeah, please remember that TB can also have fever. Having said that, you have done very well. Let me take over. Now, the key points here is this is a very important case for the exam, and these kinds of cases have come in the exam so often. So please remember, I've given you all the sequences, etc. Everything becomes easy to see. But having said that, if you just concentrate on this T1 weighted pre-contrast, I can open as an examiner this case and grill you on this case. So if you see here, this is the pituitary gland, this is the hypothalamus, this is the suprasellar system, and something is there. This something should not be there. So in TB, what happens is TB is basically a basal meningitis. So, you know, the basal cisterns, they have got debris and granulomatous tissue there, which will enhance. And this also tells you that there is what we call extraventricular obstructive hydrocephalus. The Europeans use this word. We use the word in UK, communicating hydrocephalus. In basically, communicating hydrocephalus means that the obstruction is outside the ventricular system. Please remember that the CSF goes from the fourth ventricle into the basal cisterns, goes up into the convexity, and gets absorbed with the arachnoid villi into the sagittal sinuses. So the obstruction is at the level of the basal cistern. On the cis sequence, this should have been CSF. There is no CSF. On the cis sequence, I told you when we covered the first session, there are anterior and posterior recesses of the third ventricle. This is known as infundibular recess. This is the chiasmatic recess, and these are dilated. Then this is the pineal gland. This is the suprapineal recess. So all of these are dilated, and there is ependymal interstitial edema. Please remember, this is a Viva question. It has been asked in the Viva. How many types of edemas can be seen in the brain? So one is this one. This is known as transependymal interstitial edema. Then is vasogenic edema, which is white matter, and then is cytotoxic edema, which is usually seen in cortex, in stroke, etc. So this was, now in your book, there is a differential diagnosis of meningeal enhancement on CT and MR. We have covered it previously, but here we are seeing infections. Please remember, the greatest mimicker, sarcoidosis, will always be there. So as far as infections are concerned, infections can be chronic infections, they can be pyogenic as in acute infections, and you have also seen a case of intracranial hypotension. Sarcoidosis will always be there. So dural enhancement can be done by these things, and leptomeningeal by infection, tumor, sarcoidosis are commons. So they will cause the same thing. This is, meningeal enhancement on CT and MR. And then is ependymal enhancement. So ependymal lining can also enhance, and that also is common sense that there might be infections there. This is from your old book, and one thing which I always used to teach here, this is from the previous edition of Chapman, enhancement of ependymal and subarachnoid space. So subarachnoid space, whole of the space, as in meningitis, you know, I say that as if the river is on the fire. So what is the river? The river is, as in your case, the river was the suprasellar cistern, and that suprasellar cistern is replaced. There is no water there, no CSF. Instead, there is something else which is on fire. So this is river on fire sign for me. So TB, meningitis, of course, basically it is a route of entry is usually, through the CSF. So it is a basal meningitis. But there is a concept of hematogenous spread also. So the radiological features which can be seen include signs of basal meningitis. Look at this case. Once again, you can see this enhancement in the suprasellar cistern. But with that, there can be enhancing lesions within the brain parenchyma. And they can be nodular enhancement. And once there is necrosis inside, there will be what we call ring enhancement. So all of these things can go on. Please remember, in the exam, many a times cases have come in which something is in the spine and something is in the brain, and the unifying diagnosis is that it is TB. So I'm just showing you a few examples of similar cases. This is on a CT scan, and you can see that there is enhancement here of the pia mater, and actually this is the same thing. And this was also TB, and this is a post contrast, and this is a flare which has got this high signal. And when you give contrast, it enhances. So nothing new in this case. This is multiple ring enhancing lesions. So there is a differential diagnosis of multiple ring enhancing lesions, which can be asked in the exam. It's an easy one. But just for completion's sake, this was TB, by the way. And this was all, necrosis, central necrosis. And in your book, there is multiple ring enhancing lesions, which can be neoplastic, which can be infections, which can be inflammatory, abscesses, septic emboli. These are important. Some of these we are going to cover shortly. Yes, please.
So these are coronal T1 post contrast, as well as axial T1 post contrast too. I can see, I don't have pre-contrast images, but I can see a left frontal enhancement, intra-axial. I can also see abnormally rounded enhancing lesion in the suprasellar system. Maybe it's an aneurysm.
Okay, so I let me help you, because I can understand your handicap because you don't understand anatomy-wise where you are. This was the infundibulum, and this is a post-contrast. This is a post-contrast. This infundibulum is thickened and it is enhancing. This plus this, what comes to your mind? Can you describe the findings here?
Yes, there is patchy heterogeneous enhancement of the left frontal lobe.
Okay, so you have picked up enhancement here. What's happening here and here?
There is brachiomeningeal enhancement posteriorly.
Okay, so with this infundibular enhancement, dural enhancement, some parenchymal enhancement, which goes to the edge, what comes to your mind?
Maybe sarcoidosis, maybe
Excellent.
TB, also TB.
You see, in your book, there is a differential diagnosis of infundibular lesions, and we have covered it, right? Infundibular lesions, and there is quite specific things which can happen to the infundibulum. We'll come back to this point. Okay, different case. You are reporting this as on-call radiologist, and is there any stroke, particularly on right side?
Okay, so I can see bilateral frontal subcortical or deep white matter hypodensity.
Yeah, that is age-related. I'm not interested. Any?
Okay, I can see what might appear to be, other than the obvious lacunar infarct, what might appear to be like an left MCA, hyperdense MCA sign.
Excellent. So you have picked up a lacunar infarction here. This is what you said?
Yes.
Can it be anything else?
Could be Virchow-Robin space.
Virchow-Robin space, very good. How will you differentiate between the two?
Diffusion and flare.
Say again.
Fusion weighted images and flare by MRI.
By MRI. Okay, very good. So let's go back. By the way, I am going to come back to that case, which was sarcoidosis case, which you picked up, that infundibulum case. But first of all, let's develop our concepts. And these concepts are about perivascular spaces. By the way, there is a differential diagnosis in your book, which is enhancing lesions in perivascular space. This is the first time in Chapman this has been included. And neurosarcoidosis is there. Neurosarcoidosis is the greatest mimicker in neuroradiology. So, Virchow-Robin space, or what we call perivascular spaces, are seen again in this case here. So this was the CT scan. This was not a lacunar infarct. This is a Virchow-Robin space. And the learning point is that what are these spaces, and what is the significance, particularly vis-a-vis our exam. And so I've just realized that I think I've overshot for the break. So what I will do is, let me stop here, because there's a bit of teaching involved here. And I'll mute myself. We'll come back after 5 minutes. So it's a 5-minute break. Right. So we were candidate 3. Can you listen to me? Can you hear me? No, maybe we have to unmute you. So where is candidate?
Yes,
Yeah.
I can hear you.
You can. Okay. So we were doing some concepts of Virchow-Robin spaces. So the point is that see here, this is the subarachnoid space. So this is the arachnoid, this is the pia. The vessel goes through the CSF, goes into the brain. Now, if you see the microscopic view here, this is the artery, and then this number 3 is what we call the Virchow-Robin space, perivascular space. Perivascular space is different. Don't confuse it with, the sub. So this is the brain parenchyma. This is the subpial space. This is the perivascular space. So these are the lenticulostriate arteries. These are exam arteries. I will tell you quite a few pathologies. If you know the anatomy, they will you can make out. Now, and particularly one of them is cryptococcus, which I'll show you a case shortly. So these go through this, from this M1 segment, it go into the basal ganglia. And you can imagine that it is taking in this Virchow-Robin spaces with it. The Virchow-Robin spaces are, look at this picture here. So Virchow-Robin spaces at times can be dilated or prominent as a normal variant. And they are, the key thing is that they are just like CSF on all sequences. They do not enhance. Anatomy is the key. 3 types of Virchow-Robin spaces have been described in literature, but it can be more than that. So this is type 1 lenticulostriate arteries. So in the basal ganglia region, many a times they will be dilated, and don't confuse it with a lacunar infarct. Similarly, they can be along the convexity, the medullary arteries, which go into the sulci. So this one here, this one, this one. And third one, which is described in literature, is in the midbrain. So if you look at this MR carefully, you can see this. Look at this pattern. All of these are Virchow-Robin spaces. This one is a Virchow-Robin space. Here, in the region of the basal ganglia, this is the Virchow-Robin space, and these are not what we call lacunar infarcts. Other examples. Look at this one. So many, multiple, and this one and this one. So I've seen it so commonly that people confuse it and they just report it as a lacunar infarct. Sometimes what happens is that in this example, it shows you that when you give contrast, sometimes it is not in each and every case. You can see actually a vessel going in the middle of this cystic space. So this is another evidence that this is Virchow-Robin space. Now, why is this important for us, Virchow-Robin spaces? Because some of the inflammation or infections, they go into the parenchyma through them. And when they go into the parenchyma, they will appear as if they are parenchymal. Of course, they are now parenchymal, but the pattern actually is an evidence of how did they proceeded into the parenchyma. Now, sarcoidosis is known to occur like this. It goes through the Virchow-Robin spaces into the brain parenchyma. So if you see here, there was infundibular lesion, the unifying diagnosis, pachymeningeal enhancement. This one, of course, it is parenchymal, but if you look carefully, it goes all the way to the cortex, indirectly telling you the connection. This is another case. When we reported it in our hospital, this was a young patient, 23-year-old female. Initially, we reported it as a primary tumor or solitary metastasis. There was so much edema and there was some enhancement. Initially, it was picked up on a CT scan. If you look carefully, this enhancement goes all the way to the edge. Of course, nobody just on this can say that this is sarcoidosis. I'm not showing you a CT chest, abdomen, and pelvis of this patient, which had classical signs of sarcoidosis. But having said that, remember sarcoidosis as the greatest mimicker. And then the unifying diagnosis, the differential diagnosis of infundibular lesions with this is Rico-Roman spaces. Okay, over to you. What is happening here?
So there is massive related supraventricular system with periventricular calcification, I think, as well as calcifications in the right eye, maybe bilateral ocular calcification. I think this is a congenital CMV infection.
So I lost your last sentence. Can you repeat that, please?
I think this is in keeping with congenital CMV infection.
Excellent. So this is one of the stigmata of what we call torch infections, which include toxoplasmosis, others, rubella. CMV is the most common herpes simplex. Key exam finding is that there will be, these are infections which pass through the into the fetus through the placenta. Now, the key finding is that most of these will have subependymal, what we call calcifications. And they will show you in the exam neonate with intrauterine, skull calcifications on a plain film. It used to come so often in the past. They can also show you a CT scan. Basic concept is that this is not hydrocephalus. This is parenchymal destruction. But there can be so many patterns. The key things to remember is that CMV is the most common, and subependymal calcification, various kinds of parenchymal changes, which can happen in white matter, gray matter, cysts, destruction of the parenchyma, etc. All of these things is a spectrum. This patient reported to A&E, young African female. She was very disoriented. CT scan was sort of normal. Did this MR. This is a flare sequence. This is a T2-weighted sequence. There is no enhancement on the post-contrast. But how can you explain this finding? How will you tackle it? She's young.
Okay, so I can see bilateral, fairly symmetrical, confluent IT2 and flare signal in both deep white on the deep white matter on both sides. It does not involve the subcortical U fibers. On the sagittal, I cannot see anything else on the sagittal or coronal views. So in conclusion, this is a white matter disease. It does not fit press, or also does not fit demyelination, or maybe a severe form of demyelination or severe form of vasculitis, but I'm more inclined towards white matter diseases like PML and HIV, leukoencephalopathy.
Excellent. Okay, well done. Now, candidate 3, thank you very much. Well done. And candidate 4, raise your hand, but I'll do a bit of teaching on this case. Now, this is from your old book, HIV and the brain. HIV is very important for the exam, and it can come as a long case. And I have put in screenshots from your current edition just to highlight that this is very well, there is a summary in the second part of the book, acquired immune deficiency, and both in children as well as in adults. So you can read it from Chapman, actually. Now, this differential also tells you what kind of things you should remember in HIV. There is infection and tumor. As far as infection is concerned, there can be HIV encephalitis. There can be CMV encephalitis. Both of them, the point to remember is that they will have what we call dirty white matter. This is dirty white matter. So whole of the white matter has got this kind of confluent finding. PML is very important because in PML, we will come back to PML shortly. So I'll tell you about PML on a film. Secondary infections like Cryptococcus is an exam case. It has got a unique finding, which we will learn. Toxoplasmosis and TB, ring enhancing lesions. Ring enhancing lesions, we have seen, other stigmata of TB. Lymphoma you have done. So all of these things you have to remember. The case which I have showed you is, either HIV encephalitis or CMV encephalitis, dirty white matter. So we have to see the cases of PML and we have to see the case of Cryptococcus. So,
hi.
Okay, welcome candidate 4. So, this patient is known case of HIV. There is neurological deterioration. They are worried. How will you tackle this? This thing. Please remember that there is no enhancement. I am, because of time factor, I am going fast. So I'm sort of telling you a few things in a leading fashion. Over to you.
Sure. So there are multifocal patchy confluence signal alterations, mainly involving the white matter, most marked in the left cerebral hemisphere. I'm just trying to track out to see whether the subcortical white matter is involved in this case. I can see that some area that is involving the subcortical white matter as well. And given the patient's history, so I'm thinking of deciding between the PML or HIV encephalopathy because it's an asymmetric appearance. So I will, and involving the subcortical white matter. So this will favor PML.
Excellent. So let's go back to the basics of PML. So just a recap, please remember PML. This is PML, progressive multifocal leukoencephalopathy. What is PML? PML is an infection, and this is a JC virus. Please remember that in 80% of normal brains, this virus lives there. But in an immunocompromised patient, it takes over, it attacks the oligodendrocytes and causes demyelination. Now, this demyelination, the classical pattern which you have to the books tells you that usually parietal and occipital lobe, but now people have realized that this pattern is, quite atypical. It is not symmetrical. So that was very well tackled, that it is not symmetrical. Please remember, cytomegalovirus and HIV, they will be more symmetrical dirty white matter changes. Another thing which is critical, subcortical U fibers. U as in the alphabet U. So these are known as subcortical U fibers. Involvement of subcortical, you see this one here, which is, look at this U shape, subcortical U fibers. Involvement of subcortical U fibers is one of the pathognomic signs of PML, and it will not enhance. Please remember, in the Viva, they will show you, and you will ask, I want to do enhancement. Because if it enhances, your differential changes, goes into lymphoma, goes into all those infections, toxoplasmosis and TB, etc. PML will not enhance. So previously, PML used to be diagnosed, usually they have got these are HIV patients, and the CD4 is very low, maybe between 50 and 100. But they used to diagnose it with a biopsy, but now, or since many years, biopsy is not needed because you can do CSF analysis as well as MR, and you treat it. And prognosis has also become quite good with, heart therapy, etc. The latest concept which I want you to remember is that don't go home with this idea that PML can only occur with AIDS. there is, look at this list, and suppressive therapy. There are drugs which we use for MS, in which patient can develop secondary PML, and the clinician will ask you if there are signs of PML. And look at this, such a long list. And so PML can occur with all of these conditions. This is another case of PML. Just wanted to highlight the subcortical U fibers once again. Look at this subcortical U fiber. Look at this subcortical U fiber. This U, here. So, and no enhancement once again. Yes, please.
Sure. So this is a series of MRI brain of a 32-year-old patient with known AIDS. So I can see there is signal alteration centered in the deep gray matter within bilateral basal ganglia. So I'm thinking down the road of infective causes for this with affinity in the basal ganglia includes toxoplasmosis. I'm looking for the post-contrast images in below, which shows enhancement of this rounded lesion, so which further reinforce my initial interpretation.
Hint, anatomy. My hint is anatomy. Anything comes to your mind?
Sure. And so it is. So I can see the lentiform nucleus is involved on the right side, and also the internal capsule.
Bilaterally.
Yeah.
Bilateral symmetrical type of finding.
Yes.
Anything comes to your mind? No. Okay, let me take over. This is a classical case of cryptococcus. So please remember, cryptococcus is one of the fungal infections which can occur with AIDS. You see this thing? Fungal cryptococcus. Cryptococcus becomes an exam case. Why? Because of radiology. It has got unique radiology. What happens is that cryptococcus actually so cryptococcus, it produces mucoid material, and it goes through the the lenticulostriate arteries into the perivascular spaces. This is what we learned, perivascular spaces into the basal ganglia region. And it will give you cystic type of appearance on T2 weighted sequences, for example, bilateral symmetrical. So it has gone into the lenticulostriate perivascular region, and then it has, because it has produced mucoid material which is high signal. At times it will show a bit of enhancement, and there will be other cases in which the enhancement will not be very significant. Look at this one. And it's a very unique finding, bilateral symmetrical. So once you know this, then you can make, it's an Aunt Minnie type of a case. Aunt Minnie means in AIDS, if you find it, Aunt Minnie is a case in which there is no differential because of this pattern of infection, extension. So, of course, when you see ring enhancing lesion, toxoplasmosis, TB, both of them will be there. Now, tumor versus abscess. In the exam, I can show you this case, I can show you this case, and your differential will be that it is an abscess or it is a necrotic tumor. Please remember, a necrotic tumor means it's a high-grade tumor. Now, on a CT scan with enhancement, one of the parameters which you have to describe to the examiner is, we say that if the enhancement pattern, the wall is smooth, uniform, more likely to be abscess, but if it is nodular and irregular, more likely to be a tumor like this. Having said that, there is so much overlap that we are not very good. So the king sequence for the exam is a DWI sequence. Over to you, candidate 4. What is this? Is this an abscess or is this a tumor?
So I'm focusing at the bottom slide, which are the DWI sequence, and it shows restricted diffusion, which is in keeping with the abscess.
And which part is the restriction? So this part, which part is the restriction? Is it in the wall, or is it in the lumen of the lesion?
Is at the nodular wall of the lesion, so it could mean that it's a highly packed nodular wall cells of a tumor.
Sorry. So what is your conclusion? Is it a tumor?
So I changed mine.
Yeah. So you were right first. Initially you were right.
Right.
And please remember that this has been asked in the exam so many times. So many times. Where is the restriction? If you look carefully, it is in the central portion, which correlates with this portion. And the wall does not show restriction. This is low signal on DWI, and so the portion which is because of pus. And that is how you differentiate between a tumor versus an abscess. This abscess is quite unique because in the wall there is a bit of hemorrhage, and hemorrhagic abscesses can happen, but that was not my teaching point. The main point was here. What is happening here?
So again, looking at the DWI images, I can, on top there we have peripheral enhancing lesion, and on the DWI images there is restricted diffusion, in keeping with the abscess. And
where is it going?
And it's going into the ventricle, causing ventriculitis.
So please remember that this type of scenario has been shown in the exam many a times. Now the examiner will show you this type of a scan. If you see here, subtle finding, this is low signal, but this is slightly different signal. And you are struggling if there is a level there. And the king sequence here is the DWI, which shows that within the ventricle, pus is sitting there. Actually, there was a parenchymal abscess and this. And you can also see ependymal lining, which is enhancing. So the idea was to show you ventriculitis. Ependymal enhancement. Yes, please.
So 30-year-old male, acute headache and confusions. I can on the CT there are multiple foci of abnormality in the right parietal and also in the midbrain. And on MRI, it shows post-contrast enhancement. And I'm just looking at the pre-contrast.
This one did not show enhancement. I have not given you on MR. And this thing shows enhancement.
Yeah.
What is your conclusion?
So I'm thinking this is a neurocysticosis.
And why do you say that? Convince me. And you are right, by the way.
Because the history is Mexican, so I'm going down the road.
So the examiner is very, very what we call kind, isn't it?
Yeah. So I mean, there's different stages of the neurocysticosis.
What is this stage? You convince me. What is this stage and what is this stage? Tell me more.
So on the top one, without enhancement, and there's areal calcification. So it is I believe that's vascular.
This is not calcification. This was not calcification. Let me correct you. So then, how do you explain this?
So we have a hyperdense central with peripheral low density.
So what is this stage? And what is this stage?
It's, the first one is a colloid. I'm not entirely sure, sorry.
Okay, good. At least you remember the word, so I like that. And this is the colloid. So let me come back to this. Now, this is from your book. And again, I am a strict believer in the word, I call it book memory. I think read cysticercosis from your Chapman. The second part tells you lesions can be seen in subarachnoid space. Concept 1, brain parenchyma. 2, ventricles. And you can make cases out of cases from cysticercosis. So many cases can come in the exam. But if you know the principles, you can make out the radiology, you can make up the radiology. Otherwise, you will be struggling. There are 4 stages: vesicular space, colloid stage, granular, and calcified. So let me explain to you. Basically, before I explain to you, for your interest, cysticercosis is endemic. It is the most widely distributed parasite in the world. So this is Tinea solium. And pig is intermediate host. And human beings can become intermediate hosts, orophycal route or drinking it and things like that. Eggs, I mean to say. Now, Central America, Mexico, many countries of Africa, as well as East Asia, as well as East Europe. So huge distribution. Most interesting thing is that in the area of distribution, this is the most common cause of epilepsy. So this is the clinical scenario, and this can be asked in the exam. The examiner might show you this patient presented with epilepsy, and you will not know the connection. So, the most common cause of epilepsy in the endemic area is cysticercosis. And what happens is this colloidal stage. Basically, what happens when it goes into the brain, it just sits there. The larva, so the central portion here is the central portion here is the scolex or the larva. This, by the way, is viable. It is alive and it can grow, and surrounding it is a cyst. And it will stay there. They have documented cases of it sits there for up to 30 years, and average time is about 4. Point something years, 4 point. Then what happens? It can inflammatory reaction, and this reaction becomes symptomatic. This is the colloidal stage becomes symptomatic, and the patient will present to you clinically and when you give contrast, there will be enhancement, ring enhancement. There can be what we call leptomeningeal enhancement or dural enhancement, and so it will be very acute. Then inflammation, it's slightly, it becomes, it settles down. Granular nodular pattern, and finally nodular calcified stage, which will be like this. Calcified stage anywhere will have calcification. So these are vesicular. Look at this, nodule within a cyst, nodule within a cyst, cyst with a nodule. If I ask you in the exam, you will be worried that this is a cystic space. This nodule is the key finding for the exam. So this is the vesicular stage. Colloidal, always, give contrast and it will enhance. Now enhancement is very minimal in this granular. So nobody is going to ask you this stage. Of course, calcified can be asked because of calcification. So examiner can simply show you this thing on a SWI sequence, and you will be saying, oh, is this micro hemorrhages? And actually it will be micro, small calcifications. Few differential diagnoses, just to make my point, which neurocysticercosis is in the list in your Chapman. One of them is intracranial cyst with a mural nodule. This is in your new Chapman. And if you see neoplastic and infection, so there is a cyst with a mural nodule, and the only thing is neurocysticercosis, just like this case, this nodule, it's a key finding. So only infection which can cause this. Tumors, pilocytic astrocytoma, etc. It can cause hydrocephalus, of course, because it is in the ventricles. It can present as a mass. It can present as calcification. It can also cause meningeal enhancement. So many things it can show you. Okay, candidate 4, last case for you.
So this is a 35-year-old male with headache and a series of MR which shows a rounded, well-defined cystic lesions in the right hemisphere, and there is minimal perilesional edema. So this, I'm thinking this
Any enhancement?
And there's no enhancement on post-contrast images. So this is most in keeping with proencephalic cyst.
Porencephalic cyst. So porencephalic cyst is a cyst in which there is basically a previous brain insult, such as infarction, surgery or trauma, etc. There was nothing like this in this case.
Okay.
Basically, this is the differential diagnosis of intraparenchymal cyst. So your thinking is right, but I'm not satisfied because I knew the clinical history. So over to you.
So, given the patient has got headache, I'm thinking this lesion is related to the symptoms.
Okay, let me give you a hint. You are doing the chapter of infections.
Okay, hydatid.
Hydatid. You see, hydatid has got unique features. In hydatid cyst of the brain, only about 1 to 2% of cases end up having hydatid of the brain. You can have various kinds of radiology, and there is, according to the type of hydatid has got, various types of hydatid will have slightly different radiology. Please remember the classical daughter cyst appearance or membranes, etc. can also hydatid. If you go back to the histology, has got 3 layers, and if the layer becomes crumbled inside, you will get those membranes. There can be daughter cyst also, just like you can have daughter cyst in the liver or the lung. But classical hydatid, which will come in the exam, is like this. In this hydatid, there will be no, one of the features which is very impressive is that there is no edema and there will be no enhancement. Please do not go with this idea that all hydatid will not enhance, but there are types of hydatid which do not enhance. So, so this is one of the features because you can differentiate it. There will be other types of hydatid in which there will be enhancement and you will be less confident. So this was hydatid. Okay, thank you very much. We go to candidate 5. We are tracking on to the next. Candidate 5, are you with us? Let me check. Yes, you are. Can you hear me? Maybe not. Let me see. Okay.
Hello, hi.
Okay. So this is congenital. I am going to show you about, I think, 6-7 cases from congenital, and I want to crack on very fast. And so these are the cases which have come in the exam, and then we will go for trauma. You will like trauma because all of you know trauma. So we'll go very high speed. Okay, candidate 5, over to you. And please remember all of these cases which I am showing you have come in the exam.
Yep. So these are 3 representative axial images of a CT scan in an 8-year-old child, non-contrast study. I think the most obvious abnormality is the presence of a nodular appearance of the lateral aspects of the ventricles, which have got the same attenuation as the gray matter. I think this is possibly in keeping with heterotopia.
Excellent. Use the words which, subependymal heterotopia.
Yeah, subependymal. Yeah.
Okay, let me take over. Very well done, but please remember in the exam what will happen. This is the last site you are going to see and you are going to panic. Up and down, you are going up and down and you are not going to pick up. And this is a classical case where, as I say, the eye see what the mind knows. You have to train your mind, look at this region. And this is subependymal heterotopia. So the concept is that subependymal heterotopia
Hello?
On a CT scan of CT, and you can see these nodules, bilateral nodules. And on each sequence, which will be T1, candidate 5, can you hear me?
Yeah, it's going on and off actually. Sorry.
Yeah, there was a notice on my, Zoom that my internet connection is playing up. I am in hospital, so this is the official connection. I hope it is working now. Can you hear me now?
Yeah, it's fine now actually. It was just very sporadic a bit earlier, but I can hear you now.
So, okay. So if you see here, the key thing here is that it will be equal in signal intensity to the gray matter on all sequences. This is flare, this is T1, this is T2, this is PD. And similarly on CT scan, but you can understand that this will be a very difficult case in the exam scenario to pick up. You will panic before you pick it up. So this should be one of your review areas. Now, heterotopia, please remember the concept that the germinal matrix in a developing fetus is in the periventricular region. The gray, gray matter cells, they actually develop there, and from there they get transported or they migrate laterally. They can be arrested if they can be arrested in this region, subependymal. They can go and arrest in the subcortical region like this. This is subcortical heterotopia. Subcortical heterotopia on a CT scan, this will be like a mass and you will be worried what it is. When you do an MR, you see the signal intensity is equal to other. And subcortical heterotopia is usually also involved with very prominent veins. So these filling defects are veins. It is known to occur like this. Third type of heterotopia. So this is a sort of a coronal of the same patient, and you can see that actually it goes all the way and touches the ventricle also here. Third type is this type, which is known as band heterotopia, and in which the gray matter cells, this is bilateral symmetrical, so it becomes more difficult, this particular example. But you can see that there is white matter, then there is gray matter. And then there is white matter. Band. You have seen this come in the exam, but anybody can show you. Band might be more difficult, but you should know this. Dandy-Walker spectrum, I am going to leave it. You know all of this. It has come in the exam quite a few times. Recent years, no. I think it's a very easy case. You know that there is a Dandy-Walker malformation and there is a Dandy-Walker spectrum. And Dandy-Walker malformation, of course, there is a cyst in the posterior fossa with vermean degeneration, which connects with the fourth ventricle. It might be associated with hydrocephalus, corpus callosum. In this case, there is hydrocephalus shown. But look at this complete agenesis or dysgenesis of corpus callosum. The confluence of sinuses is moved. So I will skip it. It's too easy. Okay, yes, candidate 5.
Okay. So these are axial.
Because of my factor, let me help you. Look at the foramen magnum.
Foramen magnum, okay. So in this 38-year-old patient's MRI brain, concentrating on the posterior fossa, I think there's some crowding of the foramen magnum, especially in the bottom left and bottom center image. I can't see much CSF spaces, much CSF.
So what is happening here? What is your impression here? You have picked up the finding very well.
The cord looks a bit abnormal in that image.
So if you see cord is here, something is sitting behind. If you look carefully in the next one, there is no CSF, and some anteriorly is the cord, and something is sitting behind. So now here, yes, please.
Sorry, I thought if it was a I mean, I'm just wondering if there's increased intracranial pressure and causing some herniation of the tonsils of the cerebellum.
Okay, so the patient hasn't got, but something else. You have got the diagnosis.
Yeah, so it's a
You have-
Chiari malformation.
Excellent. So this is carry one malformation. Please remember, they will show you on an axial slice, and you have to develop your eyes to pick this up. Now, the learning points in carry one malformation is that I have seen it being overcalled so many times in our reports. Basically, the criteria is that the tonsils should not be more than, if they are more than 5 millimeter, if you draw a line here in your brain below this portion of the bone. But having said that, the fine touch is that they say don't overcall it. Call it when it has got a pointed edge. If it has got a circular edge, then don't call it. If it has got a pointed edge like this peck shape, we call it peck shape, or the folia are oriented vertical, then you call it. Please remember that carry one malformation can be very symptomatic. In 50% of cases, people overcall it at times, but having said that, they forget that it can be very symptomatic. Even patient can have MS-like symptoms and things like that. So it's an important clinical diagnosis at times too, and people at times do surgeries, etc. Basic concept is that the posterior fossa has got less space than it should be. So you have to pick it up on an axial slice.
Okay.
Yes, please.
So these are sequential axial CT head slices of a 29-year-old patient. The apparent abnormality is the presence of CSF fluid within the cleft in the left parietal region. This will be in keeping with a scissioncephaly, I think. So it's a closed-lipped.
Excellent. Okay. So scissioncephaly or scissioncephaly, whatever you want to call it, can be closed lip and open lip. Basic thing is that this is closed lip and this is open lip. Basic thing is that it is lined by, so there is a cleft, it is lined by the gray matter, and this gray matter is critical because a porencephalic cyst, as we just discussed a while ago, that porencephalic cyst is a cyst because of cortical or parenchymal destruction secondary to old brain insult, like an infarct, like a tumor or surgery, etc., radiotherapy, etc. So that will not be lined by gray matter. So this lining by gray matter is critical. And so even here, you can see that there is gray matter at the edge. And this is closed lip. This is bilateral open lip. And this is porencephaly, which goes all the way to the ventricle, but it is not lined by the gray matter. And obviously, in the definition, you have to remember that it goes from the CSF of the cortex to the ventricle. So this is a type of case, this is what I call about FRCR exam, that the bar is going up and up and up. And I believe that this was a bit harsh to be shown in the exam, but it has been shown in the exam. And that's why I'm showing you. And I have given you some lead points there because of the time factor. 2 years, poor vision, endocrine dysfunction. Over to you. What is it? Look at the poor vision apparatus on this scan.
Yep. So these are several MRI slices, mostly coronal and a single axial.